Hello, my name is Dr. James R. Golding, and you're watching A Natural Healthcare Alternative, the program dedicated to your health, longevity, and well-being. I implore you today to not change the channel because we have a very interesting program today, and our topic is sciatic neuritis. Sciatic neuritis comprises 50% of my treatment day in the 25 years of clinical practice that I've been working. Today, we're going to explain what sciatica is, how to diagnose it, how to self-treat it and help it, when to come to health to see a provider like myself, and what type of treatment options are available. The other things that we're going to do is that we're going to differentially diagnose what the sciatica is from other problems so that we'll have an idea and you'll have a greater understanding of the nature of the condition to know whether you're getting the right care and treatment for the nature of the problem. Sciatic neuritis essentially is a radiating pain that stems or has its origin in the lower back and radiates a pain either into the hip or down into the leg on either side. Sciatica is a condition that can come on as a result of an injury, which is most common. A person strains their back, overlifting or getting themselves in a weird position. So trauma is one of the most common origins of the condition. Secondarily, it can be age or degenerative-related problems that cause sciatica or this radiating pain into the lower extremities. Third, it can be the onset of a disc problem or some type of inflammation or degenerative disc disorder in the lower back, which is not one of the more common origins. It only comprises 5 to 10% of what is the origin of a sciatic neuritis or a radiating pain into the lower extremities. Now, a person with these symptoms, and most of the time they're one-sided, there's only 5% of the time when people have this radiating pain stemming from the lower back that comes into both legs. Usually when that's the case, frequently we have disc involvement of the case, so we're able to diagnose and figure that out quite quickly. So a person comes into the office and they're complaining of either lower back or hip or radiating leg pain. Now keep in mind, a person can have sciatic neuritis and have no symptoms or pain in the lower back or into the buttock, but just pain or symptoms into the lower leg, numbness or tingling, or radiant symptoms in other aspects of the leg. Sometimes a condition similar to sciatic neuritis, known as femoral neuralgia or other forms of radiating pain, will take on characteristic symptoms that are similar and or the same. Frequently, a person will come in and think that they have a hip or buttock problem when they actually has the stem or origin in the lower back with this condition. So we're able to screen and differentially diagnose these problems as we go along. So a person comes in, they fill out a history form, we take a history of the nature of the condition. Then what we do is we go in and we do an examination, which we're going to show you coming up. We're going to give you the criteria of how we actually differentiate this problem. Sometimes imaging is necessary. We go ahead and we take x-rays of the lower back, or usually sometimes we'll take an MRI or do a CAT scan of the lower back. Most of the times, those forms of tests are not necessary because we're able to conservatively manage the condition without going into a further understanding of the nature of the condition. Most of the time, it's right on the surface. So when a person comes into the office, if we hit it right on the key, we're able to initiate the nature of the treatment right away when they come in. Before we start our thing, I'm going to go over a few minutes of anatomy so that you have a little bit of an understanding of what's going on. Now, what we have here, I brought a few charts with us today, and what we're looking at, now keep in mind, the sciatic nerve is the largest nerve of the body. It's the size of your thumb. And when that nerve gets either compressed or inflamed, a whole host of symptoms into the lower extremities can occur. This is looking at a chart of the nervous system, and what we're looking at here, these regions right here, this is the lumbar spine. Usually there's 5 vertebrae in the lumbar spine, meaning low back or lumbar vertebra. We have the sacrum. We have the nerves exiting out of those vertebrae, which then take and traverse down in through your pelvic area and down into your legs. The nerve involved in this case is this sciatic nerve. very, very large nerve. Most of the time it traverses the posterior aspect of the leg, so most of the symptoms we're going to get are into the buttock or into the posterior aspect of the leg. There's a nerve up from that called the femoral nerve in this region that supplies the innervation or the actual nerve supply to the anterior or front portion of the leg. So with that anatomy involved, that's what we should know to start. Now, in looking over at this chart, sciatica or lower back dysfunction can either be muscular in nature, dealing with too much tension of the muscles or muscular imbalance. It can deal with an imbalance of the pelvic area of the lower back. It can deal with mechanical malalignment or fixation. The joints are stuck in the lower back, and that's contributing or causing the pinching of the nerve supply in the lower back. So in a quick look-see here we have a chart that shows a degenerated disc in the lower back. This is a normal healthy disc, disc being the pad that rests in between the vertebra. A disc is a large ligamentous area. If we're going to look down on this region, it's a large ligamentous area that has a semi-soft center to it. As a person gets into midlife, it's similar to like silly putty in consistency. As we get older, it's similar to like day-old spaghetti in consistency. And then if that disc can either compress or move, and that can cause one aspect or compression of the nerves. What they're showing here is a degenerated disc. This is a downward compression of the disc area in the lower back that is resulting in a narrowing of the neural foramen or actual anatomical disc opening of the lower back. Having a degenerated disc doesn't necessarily mean that you're going to have lower back pain or sciatica. However, it is a definite predisposition for having the nature of this condition. So that's something that we would diagnose by X-ray. If a degenerated disc is involved, frequently it can influence the amount of time and rehabilitation involved with the condition. One thing to keep in mind, sciatica can be debilitating. A person can have dysfunctional pain with sciatica. Does not necessarily mean that it's either, number one, going to take a long time to treat, or that there's a lot of involvement as far as disease or disorder goes. So the pain can be great, but frequently we can manage it in a short period of time. Usually, the further down the person's leg that the symptoms go, that means not only that there's more pressure in the lower back creating those radiant symptoms, but the condition's worse the further it goes down the leg. Usually what we find is that as we treat and the nerve heals, it's going to heal from the lower back down into the buttock and down into the legs. Sometimes it may take numerous weeks for that nerve to heal along its course. What we're looking at here is this is called a facet syndrome, and what they're demonstrating at this point is they're demonstrating that the actual mechanics of the joints, basically you got a stuck joint in the back, and that stuck joint is what is causing a locking of the normal motion of the lower back and is contributing to the compression that's occurring in that area. What we're looking here is called spondylolisthesis. It's a congenital fracture of the lower back that it allows for abnormal shifting or moving forward of the lower back vertebra, compressing and entrapping the nerve. One of the most common causes or reasons for sciatic neuritis is something called a subluxation. That's an actual mechanical malalignment or meaning a misalignment of the lower back vertebra that's stuck out of position, entrapping the nerve and thus creating the radiant symptoms, which we're going to be talking about in just a moment. Spinal stenosis, or this actual picture here, what this is demonstrating is that there's an actual narrowing of the spinal canal, the actual opening where the spinal cord and the spinal nerve root exits out of the back. This is a congenital phenomenon that a person can have and be asymptomatic throughout the course of their life, but usually it's associated with sciatica when they have it because it's a congenital narrowing. They can still respond well to treatment, but there's a higher incidence of having this condition, having the sciatic neuritis when they have this condition. What we're looking at here is a transitional vertebra. This is what's called a congenital anomaly or congenital weakness in the lower back that deals with the way in which the back is formed in the womb that increases the likelihood for having spinal problems. The other here is called a tropism. Tropism is when the actual facets or the way in which the joints are positioned dealing with the way that you're born can create a functional weakness in the lower back. And now please stay tuned because we're going to transition into us doing the examination, self-treatment, and evaluation of sciatic neuritis and radiant nerve symptoms into the lower back.
I can listen.
I can cook.
Good. I can coach.
Kids with something to do are less likely to do drugs.
I can drive.
I can paint.
I can dance.
A little of your time can make a lifetime of difference.
I can read.
I can help.
You can help. Call toll-free 1-877-KIDS-313 to find out about community drug prevention programs.
I can keep a kid off drugs.
These kids are in trouble. They're not getting high on drugs or stealing. If they were, you'd do something about it right now. But why is it almost half of all parents who suspect their child has a problem learning wait a year or more before getting help? Why? Kids with learning disabilities are smart. They just learn differently. Call now. The sooner you get help, the better the chance your kid has.
And with us today is the illustrious Mary Ethel Schmidt, actress, producer, and director, and acting teacher from Manhattan, who is out to be our assistant today. Mary Ethel, thank you for coming and joining us today. And then there's the venerable Dr. Kenneth Kirsten, who he and I work together, and he's going to be going over the examination and stretching procedures and the criteria for greater understanding and self-care. Take it away, Dr. Kirsten.
Okay. With the good review that Dr. Golding gave in the beginning, there are many different types of conditions that can cause low back pain and radiating leg pain. Let's talk about sciatica first. Okay? Sciatica is a compression of the sciatic nerve that exits the low back and goes down into the leg. People would have symptoms or complaints of pain upon sitting, causing pain that radiates into the leg, and they feel better when they stand up and move around. It's a very, very common thing. And again, as we're taking an in-depth history and exam, we could diagnose or discern these conditions 80% of the time just through our history. And what we have to do is find out exactly what the condition is causing the sciatica or the symptoms and treat it appropriately. Another condition that we're going to discern between is a great mimicker of sciatica, and it's called sacroiliac syndrome. Sacroiliac syndrome has more to deal with the facets in the low back and the part where the pelvis meet the spine, the sacroiliac joint. It's a very, very common area of complaint that people think that they really have true sciatica, but it's actually a mimicker of sciatica, and we're going to discern the difference between the two because the treatment is actually quite different. What we do, of course, take a great history, make sure everything's okay with the patient, and we go through a physical exam. We would always do orthopedic examination and do a neurologic examination and check reflexes, muscle strength, things of that nature. At this point in time, we know where we're going to go with this patient. If we already feel that they're too far gone, that we can't help them at all, we're going to send them out, refer them, maybe order an MRI, find some more imaging. Most of the time, 90% of the time, we could treat these people right away and get symptomatic relief. So after doing a neurologic examination and going through our history, we're going to go through the orthopedic examination. And we're going to go through some basic testing that's going to help us differentiate between the conditions. So Mary, let's have you lie on your back. First and most common thing we're going to check for is what we call nerve root tension signs, things that are going to cause tractioning or irritation to that sciatic nerve. And one of the easiest things we can find out is a straight leg raise. And what we'll do is we'll have the patient totally relax, and I'm going to passively lift the patient's leg. Now, if a patient has a hot disc or a really hot back, I'm going to get about this high, and they're going to feel pain that's radiating and shooting. But we're looking for a reproduction of the pain, not just tightness in the hamstring. We're looking for an actual reproduction or eliciting that symptom. So back pain and shooting pain down the back of the leg. And a lot of times I can't get the patient higher than 20, 30 degrees. Then we'll actually check the good leg. If the pain is here and I lift this leg, sometimes we'll get radiating pain down the symptomatic leg by lifting the good leg. that tells us there may be more of a central compression or maybe a disc herniation or a more significant injury here. So if at that point that I find this, now I'm leading to sciatica. And what I'm going to do is I'm going to check. We're going to cause compression behind here. I'll drop the leg to where she doesn't have the pain any longer, and I'll squeeze behind the knee. And if that elicits the pain, those are two tests right now I know that she pretty much has a nerve root tension sign or irritation as the nerve exits the spinal column. If, for some reason now, she has a lot of leg pain and she has a history of sciatica and all this, you know, the typical symptoms, but I got the leg and I'm going up, I'm going up, I'm going up. No pain, no pain, no reproduction. Now I just feel some tightness in the hamstring here, but no reproduction of the pain, no tingling, no numbness. Now I'm leaning away towards sciatica. I'm leaning away to the disc problem. Because if I do this and she had a hot disc, we're loading that nerve right there. She's going to be wanting to jump up and grab the chandelier. We call that chandelier sign. She's going to want to just jump off the table. She's not going to feel comfortable with that. So now I want to test the facet joints and see if there's irritation in those areas. I'm going to take the leg like this, put her in this position, and a lot of times when we compress this like that, she'll feel that pain right there. It'll be just pinpoint. So now we're getting somewhere, and I'll test always the good leg. Sometimes we don't feel anything. A lot of times this is more flexible. And then what we'll do is we'll have the patient turn over. Now what we're going to do is we're going to challenge those facet joints and challenge the back into an extension position. That's going to really tip us off to whether we're having more of a sacroiliac or facet syndrome as opposed to sciatic neuritis. We'll bring the leg up like this, and I'll just put my hand here and I cause an extension. If she has pain, now we're onto a hot facet. Now we're on the irritation and extension. We'll check the hip. We'll rule that out, make sure that the rotators are okay. A lot of time it could be just an inherent problem in the hip, like Dr. Golding said before. And a lot of times another thing we'll see is a tightness in the piriformis muscle. A muscle, it's a triangular, very strong muscle. It's a rotator of the hip. Sometimes with the spasm of that muscle right in the buttock here, that can also mimic sciatica because that nerve is so large, it runs through the back here. What we're seeing is a spasm of that muscle causing irritation, and in some % of the cases, you will actually have that sciatic nerve piercing the muscle in the anatomy. So if that's spasm, that's hot, that will cause the pain. So now we have a good understanding of what's going on, and if we have sciatic neuritis, we're going to treat the disc. We're going to treat the nerve. You can turn on your back for me now, Mayor. We'll do things of electric stimulation, ultrasound, decreasing inflammation. We'll have them get maybe anti-inflammatories from their primary doctor, anything to help facilitate decrease in inflammation, taking their pain away so we can get aggressive with the therapy. A very excellent technique that we use for sciatic neuritis and disc compression is flexion distraction. It's an actual traction table that we use. We do direct contact and cause a gapping or a pumping action to help take pressure off the nerve and help reduce disc inflammation. If it's facet syndrome, we do a lot of flexion exercises, reducing muscle spasm in the back, and we'll do our traditional manipulation. The key is manipulating that sacroiliac joint, getting mobilization in there. And the big thing we hear with this is I'll have patients that come in the office for years of low back pain, They've been through physical therapy. They've been through cortisone shots, no response. That's leading to sacroiliac. 2 weeks usually where they're better with manipulation because they just need mobilization of that joint. And we get that mobilization of that joint, the inflammation is decreased, and the patient's responding. Now what we're going to do is we're going to go into some home stretching to help you to do some things at home to help you with your condition.
Faster than searching the World Wide Web. More inspiring than a half-cap mocha latte. Able to answer any question with insight and detail. This superhero of knowledge can find the answer to any question no matter what the problem. And she works in your neighborhood at your public library. When you need to know, get to know your library. Log on to njlibraries.org.
Each year, thousands are senselessly killed by people with no criminal record at all. People like you.
Dr. Kirsten, with these stretches that you're about to show us, can a person that's even in acute pain start to do these stretches?
Absolutely. And sometimes we'll do these stretches in the very beginning when the patient is in acute pain to help them out at home, and that will help our treatment. So if we're talking about sciatic neuritis and we're looking at a disc problem or nerve compression, typically what the patient feels better, which used to be taboo in the old days, is put the patient into an extension position. Again, then we're going to discern between, disc and facets. With sciatic neuritis, extension most of the time feels better. Backs don't read books. They can present however they want. So, but what we'll do is we'll put the patient into an extension position. Turn on your tummy. And there's specific protocols for these called McKenzie protocols. But what we're going to do basically is we want to centralize the pain. The number one thing we want to do is draw the pain out of the leg up into the back. Even if the back pain gets worse, but the leg pain goes away, that's good, and that's what we want to achieve. So when the patient's laying on their stomach, we have them lean up on their elbows like they're maybe watching television on the floor and let the belly sag. And if that feels good, typically with a disc problem, the pain will be drawn up out of the leg. They feel more pain here, but that leg pain goes away. So we'll have the patient just do this at home. Lay on the floor, do some sets of this. Just lay on the floor, let the belly sag, hold for about 10-15 seconds, lay it back down, rest, and then go back up and do that repeatedly. That helps them with something they could do right at home.
Mm-hmm.
Okay? Now, on your back, Mayor. If it's a facet syndrome or irritation of those facet joints and we're having joint and flexion problems, what we want to do is cause flexion. And we would not want to do this in sciatica because then we're loading the disc. So what we're going to do is have the patient bend their legs. And what this is going to do is going to do two things. It's going to cause some flexion in those joints, and it's going to help stretch those muscles out, those big paraspinal muscles that are spasmed and hot in this condition. So what you're going to do is you're going to grab onto your legs, interlock your fingers. We like to do 2 at a time so we're not torquing the pelvis out both at the same time. What we're going to do is you're going to have the patient, now the patient should feel comfortable, like, oh, this feels good. So what we'll have them do is they'll do a little stretching at home, some isometric contraction and relaxation. The patient is going to push their knees away from their hands, straighten out their elbows, and cause their back to be rounded out or pressed into the floor. Hold for 10 seconds. Then they're going to exhale and pull the knees to chest. And then they're going to relax. With that extension or pushing away, it's causing a contraction isometrically, and then we're shutting the muscle off, relaxing it, getting a nice stretch. And they're going to do this 5 times. 10 seconds out and 10 seconds in. After that, they're going to gently drop their legs, and with those, they're going to progressively work their way up closer and closer to the knees to chest. After this, we're going to work on the quadratus lumborum muscle, another muscle that's kind of at here that causes a lot of spasm. And what they're going to do is they're just going to gently let their legs fall to one side, and they're going to let gravity do the work here. They're going to feel they feel that tension here. Hold for about 10 seconds. They're going to exhale. This will feel good. Come back up to neutral position again, not going to the other side. Then they're going to go again to the same side, and then they're going to begin to reach up and stretch this way. And they're going to do that 5 times, progressively working closer and closer to the floor, to the left, and then 5 times to the right. Okay? This is a good morning stretch. This is a good, I always tell the patients to do this once in the morning at least, and once before they go to bed at night. Bare minimum. They could do this throughout the day. It's best to do on a floor, not a bed, so they're not sinking into the bed.
Is this a good preventative exercise for the lower back?
Absolutely.
And one for someone that has a history with that?
Yeah, particularly, people that have a chronic, low back condition, spasm muscles, tightness. This is good to loosen up those major muscle groups in the low back, the paraspinal muscles and the quadratus lumborum muscles.
I find that people stretch their spine straight away, which I advise if they're in acute pain to open up the neural foramens, but it seems like they always have that rotational restriction going on. I think that's really a good one.
So now after that, we're going to see if they have any tightness in the buttock muscle. And this is a really good stretch, and patients love this stretch because it really gets in there. It's a lot of times they say they've been given stretches, they do stretches, but they can't get into that spot that really, really irritates them, and that's the buttock muscle, the piriformis muscle, like I explained before. That's a really strong muscle, and get really spasm, and this is the way to loosen it. What you're going to do, first of all, in this position, they might even feel some relief or feel that stretching right in there, right in that buttock area, right there. And that's going to help that muscle relax. So what I'll have them do is I'll have them either just lay on the floor with their foot against the wall like this, and they could just bend this knee a little bit, let the leg slide down, and it causes this leg, using this as a fulcrum, to stretch this leg out. So it's very, very easy to do. You don't even have to, minimal effort here. But what I'll have them do to do an active contraction and relaxation, just gets a little complicated in there. Hang in with me. Okay?
That's a great stretch.
Yeah. You're going to do this. She's going to actively bring her leg, try to bring her leg into her hand. She's resisting with her hand like this. So what she's doing is she's contracting the opposite muscle group, helping that muscle shut off. After 10 seconds of doing that, then she's going to take this leg, reach through here, take this one, reach through the hole, and she's going to pull this leg up like this, and that's going to feel really good right in here. And the same thing, she's going to hold for 10 seconds and then relax. She's going to do that both sides, 5 times on this side, always twice, both sides, 5 times on this side.
That's an awesome stretch. Keep in mind that with sciatic neuritis, the sooner you get it looked at or treated, the easier it is. So I'm not advocating that after a few days, if you have the nature of this pain, you should get it looked into, because most of the time we can sum and deal with it right away. The other thing to keep in mind, with sciatic neuritis, do not under any circumstances put heat on it, because it's gonna swell and inflame the condition and make it worse. If people did that, you know, it's going to make a big difference. Thank you for watching today, and thank you, Mary Ethel, for coming and spending the time with us today. And Dr. Kirsten, your knowledge knows no end.
Thanks.
For Natural Healthcare Alternative, I'm Dr. James R. Golding. Thanks for watching.